Thank you for joining us for our weekly briefing on preventing and managing COVID-19 in the workplace. This is our 38th consecutive week. This is Karen O'Hara. I'm the Director of Marketing and Communications at WorkCare and your moderator for today's session. Many of you are regular attendees, and we welcome you back. And if you're just joining us for the first time, be prepared for another exciting episode in this ongoing story of COVID-19 in the workplace. This session is being recorded. You'll be on mute during the webinar. Please submit your questions using the Q&A function in Zoom. At the conclusion of Dr. Harris's formal remarks, we'll answer as many questions as we can in the time we have allowed, which is about 40 to 45 minutes total. All the questions and answers are posted on our website within a few days, and we post the recording on our YouTube channel, so you can refer to those sources. They'll be posted during the webinar in the chat. Most of you know Dr. Harris, our presenter. Anthony Harris is an MD, MBA, MPH. He's board certified in occupational medicine, and he's WorkCare's Chief Innovation Officer and Associate Medical Director for on-site clinical operations. He's also our lead clinician for our COVID-19 response. And today he's joining us from our offices in California. So he's in a little bit different time zone than normally. He's usually in Chicago. So in the interest of time, I'll turn it right over to him. Thanks again.
Wonderful. Thank you, Karen. Thank you, everyone, for joining us once again. And greetings from sunny Anaheim. Definitely a change of weather here for us today. And we're excited to dive into today's topic, which is going to be a little, feel a little different, perhaps, than what we normally take. It's going to be a light day, quote unquote, if you would. But we're still going to get into something that's pressing for many of our employers in regards to the impact from COVID. And in particular today, we're going to talk about and focus in on mortality. So without further ado, you know our process in terms of the schedule. Clinical update comes first, followed by some pathology and microbiology. And then we're going to get into the epidemiology, look at globally how we're doing. Obviously still being impacted disproportionately so compared to our neighbors. And then prevention, and finally a little strategy as it pertains to our take on how to help your workforce during these times. So today, clinical presentation that we want to discuss is focused in on a kind of a specific issue that clinically has been evaluated recently, and that is hepatic factors. Hepatic meaning liver, right? And what we want to examine today is risk factors for mortality. And we're focusing in on hepatic factors, liver factors, because that's been a bit of study that has elucidated some increased risk for those individuals with pre-existing hepatic dysfunction. And this particular study looked at those individuals who presented with elevated enzymes in the liver, that's AST and ALT. We won't get into the full name of those enzymes. We can certainly do that if there's any questions about it later, but we also looked at in this study pre-existing cirrhosis. And what this study found, why we're talking about this today, is that those individuals who presented with these elevated liver enzymes that are commonly measured when individuals are admitted to the hospital, particularly the ICU. If these levels are elevated, including disease of cirrhosis being chronic inflammation of the liver, if you would, these individuals, in some over 3,300 that was looked at in this particular study, 18 or older who were positive for SARS-CoV-2, did more poorly, right? They had increased risk for mortality. And this is still an ongoing series of studies that is being conducted looking at this phenomenon of associated liver dysfunction and increased mortality amongst those who are admitted to intensive care units. If we examine now other studies, this was presented in the Journal of Internal Medicine from JAMA. And we, in this particular study, looked at, or this particular report, looked at 3 different studies. We'll focus in on just the highlights from this particular report here. And over 784 of 2,200 adults, which is 35%, were admitted to ICUs that were and became a part of this particular study. This study also looking at, again, risk factors for mortality. And the study found several factors that play a role in mortality, including advanced age, which we all know, right? Male sex, which we talked about briefly months ago, higher than normal body mass index. That one being less prominent in terms of communicated to individuals of actual risk factors. So hold that one in for a little bit. And then coronary artery disease, we've talked about. Cancer, we've talked about. Low oxygen levels, we've talked about. Kidney and liver dysfunction being prominent risk factors. Again, something that is still burgeoning in terms of our understanding of these pre-existing conditions, increasing the risk for mortality amongst those admitted to hospital and ICU settings. So as we continue to focus in our pathology, looking at mortality, looking at factors that contribute to mortality, particularly here in the US, if this is not a sobering bit of information here, I don't know what would be. So COVID-19 ranks as the top 3 leading cause of death at this point in time in the US. That trumps other countries, peer countries, in that regard, in terms of leading cause of death. The only country that comes close to us is Belgium per population. So this is why we're focusing in on this today. And this is what we want to hold in your mind so that we can prepare our workforce for continuing to weather the storm through this pandemic. Again, we know the vaccine is on the horizon for our workforce. We know that first line, frontline workers are being administered the vaccine in weeks to come. And so we still know that it won't be until early next year, Q1, that we'll start to have administration to our workforce that we serve for the most part with those essential workers, critical workers abroad. So we're going to continue to see rising numbers of death in terms of families impacted, and we need to have strategies to help deal with that. As we examine more the pathology behind these causes of death, again, highlighting why this is important to understand fully, this particular study published recently looked at particularly 17,000 hospitalized COVID patients between February and June of this year. And what this study was looking for, again, was risk factors associated with mortality for these hospitalized individuals. And so if there's no doubt, the age is by far the #1 risk factor, right? If we look at the bottom, this particular graph is giving us odds ratio. We talked about odds ratio, I believe back in August, when we talked about how calculating the odds ratio is done and what the odds ratio means. To revive that here, refresh that here for you, odds ratio essentially is communicating the risk of the outcome, in this case, death, as a result of the factor we're trying to examine, and obviously age, metastatic cancer, etc. So the odds ratio for age 75 or greater is by far the #1 increased risk for over five on the odds ratio, right? If we go to the next, in terms of metastatic cancer, we're looking at odds ratio just above 2. If we look at then what we just presented in terms of association of liver disease, it's up there now, right behind cancer. So in totality, the impact from liver disease is significant in terms of its impact, its risk factor for mortality, even more so, right, according to this comprehensive study, than respiratory performance. So again, we want to be cognizant of communicating risk factors appropriately to our workforce so that they, in this midst of having COVID complacency, right? Or everybody, we've talked about COVID fatigue and how workers are now taking the stance of, I'd rather just get sick and get it over with. Reminding them and communicating to them the risk factors, not just for themselves, but for their family members, being broad and being substantial, may help in their responsiveness to adherence to safety precautions, both in the workplace and obviously in the community, in the home. So let's jump into the epidemiology. Let's see how the US is faring. Obviously, you see the news, you see the numbers continue to increase. 2 weeks ago, we were at 11.1 million cases, 47.5 on a 7-day rolling average per 100,000 individuals. Last week, that jumped to 12.3 million with 52.3 per 100,000 in terms of 7-day rolling average. And we're at over 13.3 million at this point in time. The 7-day rolling average down a little bit from last week. We'll see this reflected here subsequently in additional metrics that we're going to look at today. If we're talking about deaths, 11.1 million cases with a 0.4 per 100,000 deaths was where we were 2 weeks ago, increased to 0.5 last week, and we're still at that 0.5 rate per 100,000 individuals this week. Looking at total number of cases compared to our neighbors, again, 2 weeks ago, obviously, total number of cases, no one comes close to us. If we look at trends over time, 2 weeks ago versus last week, still trending higher, obviously. And we saw on a 7-day rolling average a little dip here from where we were 2 weeks ago. We'll see that most likely bump back up. We're already seeing it on a daily case rate that we're handling internally with WorkCare and our employers. We'll likely see that play out abroad after the Turkey Day holidays that we just had, and this number popping back up in next week presentation here. If we look at per million, again, where we were 2 weeks ago with the number of cases on a 7-day rolling average, continuing to jump up there as other nations like the United Kingdom dropped. And then we saw a little decrease here in the US. Now, is this this dip here attributable to some of the precautions that were put back in place, some of the shelter in place orders that were given, as we know, in the last several weeks? Perhaps, right? We'll continue, if we continue to see decreases in this number, that may speak more to those measures having a positive effect. But certainly we'll see that tempered most likely by the holidays and travel that we know still happened, and these social distancing practices not being adhered to in terms of household communication with others, household dinners together. If we're switching now to deaths, looking at COVID on a 7-day rolling average, where we stood last 2 weeks, where we stood last week with the trend continuing to increase and seeing a little dip and then jump back up here over the last week and as it stands today. Again, with this being a 30-day lagging indicator, we'll likely see this continue to increase here moving forward. Now, when we look at per population, per million, United States still lagging 2 weeks ago behind our neighbors in terms of relative deaths per population, still in that same position last week, and jumped up a bit this week. We don't have France on this particular chart, but again, we're still behind France in this regard. If we're looking at daily new tests, how are we faring? Are we increasing the number of daily tests? The answer to that is yes. This is where we were 2 weeks ago, just under that 1.2 million on a 7-day rolling average. Went up quite a bit by 200,000 over the 1.4 million mark last week, and began to dip down again and continues to dip back down towards that 1.2 million as we crested 1.6 million in the interim. So we'll continue to watch this overall trend, which was trending up in terms of number of tests. We know that across the board, we're seeing now backordered supplies for COVID-19 testing amongst our suppliers and manufacturers. We'll see how this plays out in terms of, are we going to continue to see a dip in number of daily tests on a rolling average here, or are we going to see, hopefully, this number continue to trend up overall because supplies are being replenished? If we look at per 100,000 in the US wise, we were behind the UK and France 2 weeks ago. Looking at last week, continue to be behind the United Kingdom, although we increased beyond France in terms of tests per 100,000. And this week, again, in that similar position behind the United Kingdom. If we are looking at now our trend to understand how we articulating the burden of disease, 2 weeks ago, still seeing that trend increase. That was the beginning of sustained increase from a trend standpoint. 2 weeks ago, we saw that dramatically increase from during last week's presentation, and we're still seeing that dramatic increase during this week as it stands today. And again, what this represents is that the number of positive cases actually in the communities is likely to be drastically higher than what we're articulating through our testing efforts across the board. If we zero in on some statistics, Illinois, for example, it's estimated that for every positive case we detect from testing, there are 8 more cases that go undetected because they are either asymptomatic and have never been tested, or people just aren't testing at the numbers we want them to be tested from a global perspective. So again, that gives you reference to the impact of COVID and our ability to articulate accurately what the burden of illness actually is in the community. This obviously has an effect on our ability to protect our workforce from a community spread standpoint, but particularly from a work-related standpoint, we want to make sure we're talking about what the impact on from a mortality standpoint is going to be as we continue to weather this pandemic. So focusing in on work-related deaths from COVID-19 is an important topic, right? It hasn't gotten a lot of press lately because of several factors, I believe, in regards to reporting work-related deaths from COVID state to state. And so this article speaks to a number of, or a trend across the US of COVID cases, particularly COVID deaths, that are not being reported by employers. And there being a substantial number that just go unreported prospectively. In particular, looking since May with this particular examination of a employer that had a scenario of 274 confirmed positive cases in a extended residential care facility, led to several deaths. One of them being a Mr. Walters, who was 53 back in May. He succumbed to the illness, along with several of his coworkers, right? And in this particular case, state and federal law obviously mandate that workers who succumb to COVID-19 from a work-related exposure is reported by the employer, right? And that pretty much is the standard for most states. However, the trend we're seeing is not reporting because, as in this case, the facility deemed these deaths not related to a workplace exposure, all right? So they did not report it. Same thing happened for the other deaths that occurred, again, 4 total in this particular case. So it's a pattern that we want to point out because it's important to understand how the causal relationship is created in the workplace for the workplace exposure by your teams, right? Your HR managers and or hopefully some clinical consultants that you brought on board to help in these determinations. And why is that important, right? We're looking at globally what the excess deaths are in terms of US wide, and this is figures presented now by CDC examining excess deaths on a rolling basis here as a result of COVID and a result of just baseline excess deaths from all other causes. And so the other causes are what we are seeing in the green yellowish color here. And there are indeed excess deaths from all causes that occurred in January. And you see the deaths in this histogram above that baseline curve there. Anything above that baseline curve, particularly the curve, the histogram that's in the blue, those are attributed to COVID deaths in excess of what we would normally see between that April date and where we are currently here today. So there is a substantial numbers represented here. 60,000 as a general baseline during that time period, bumps up to almost 80,000 in certain time periods. So 20,000 increased deaths attributed to COVID-19 in excess of what we normally would see. And we've presented this type of data obviously in the past. And we want to continue to point this out because it impacts our workers, it impacts families, and we have to communicate effectively as we move forward the risk factors that exist in our workplace for contracting COVID-19. And we got to do a good job of making causal associations so that we can accurately articulate the impact of work-related COVID deaths. So when we talk about then our strategy of prevention, we really want to focus in on and reflect back to some similar tactics we've taken to help understand COVID causality relationships. We talked about a COVID fitness for duty, where we're trying to understand the individuals who have several factors such as prolonged PCR positivity, persistent symptoms, the repeated quarantines, and limitations as a result of COVID-19, right? We talked about this again in reference to how do we understand true impact of COVID on a worker's ability to perform their duties and make that causal association as accurately as we can. And when we examine these symptoms and these factors, we want to then translate that into several steps that need to happen, as we spoke about with the fitness for duty, again, moving the individual through these steps to make that causal association finally in concert together with employer and clinical consultant, right? Examining the actual clinical findings in detail enough to understand what are the ongoing risk factors in the workplace that may have led to these symptoms, as well as obviously in this case of mortality, what led ultimately to their death, right? So it's a deeply clinical determination that if you contract COVID-19 and you end up passing away, you have an instance of someone passing away with COVID-19, the clinical consultant in that case would be the means by which you make a determination of one, was the cause of death truly, was the likelihood of the cause of death truly being COVID-19 versus other pre-existing conditions, and then what's the likelihood that the illness, COVID-19, was contracted in the workplace, right? And so it's a deeply clinical determination that we should have as a tool in our armamentarium in terms of helping employers mitigate risk from a litigation standpoint of workplace caused death from COVID-19 transmissions. And we may have talked about this some time ago from a causality analysis standpoint, but I want to bring it up again so that we can understand what are some best practices that we have in place to help in that causal association determination for, in this case, zeroing in with causality of COVID-19 mortality. So looking at the history of exposure is key, right? Obviously every EHS and HR manager will be evaluating the history of exposure in the workplace, but doing so in a manner that we can then articulate risk as a result of that exposure, right? That's the heavy lifting that your clinical consultant should be doing in concert with you. The established diagnosis is key in terms of trying to understand, is the cause of death, COVID-19. Obviously, consultation from physician to physician would be very beneficial in these causal associations, right? Picking up the phone, Dr. Harris picking up the phone, calling the clinicians at the local hospital and speaking about, is the cause of death truly from COVID, or was it pre-existing conditions that led to the outcome, and helping formulate then the opinion at the end of the day of whether or not this was all associated from a workplace exposure. Obviously, objective findings would be key in regards to the nature of the exposure, the timing, basically the magnitude of the exposure. Was there a cluster event with multiple workers, et cetera? All these factors play a role in the causal association. And then we want to go through our litany of factors that contribute to, in a gradient fashion, if you would, those items that are important for determining causal association. So these factors we've presented before, and we want to bring them up again because they're important to understand proportionality, right? Strength of association really is looking at the evidence of what the exposure was and what the circumstance was that contributed to the outcome, all right? In this case, looking at those workers that perhaps are in the meatpacking industry and the associated conditions that they work in, and the association of transmission rates in that particular scenario. And that gets played out on this scale, low to high, in terms of risk. Consistency of evidence is looking at the body of evidence around that particular exposure and that particular causal potential outcome, right? And so in this case, COVID-19 in concert with pre-existing conditions contributing to mortality would be something that's examined with this particular metric. And then specificity of the result. This one's more straightforward, right? Was the death caused by COVID-19? And this is that where the peer-to-peer portion of this causal analysis plays out very prominently. Then temporal relationship is the overlaying transmission and contraction of COVID-19 appropriate for the timeline of cause of death. Biologic gradient is referring to the kind of global exposure pattern that we saw for this particular case. Was it a cluster? Was it not? Was it a continued exposure over a period of time from a potential positive individual in the workplace? And that plays a role, obviously, in terms of likelihood of it being work-related, contributing to the transmission, and then finally to the outcome, the mortality, the death. And then coherence is more a global focus item in terms of understanding, does it all fit from a biologic standpoint in terms of what we know about the disease and the potential outcome, what we know about the exposure and the potential outcome. And this, again, is the final factor that we then play out with a proportion. And that possibility that we talk about, medically possible, that this transmission led to the death, only needs to cross a threshold of greater than 50%. So if it's possible, and or if it's less than 50%, then causality is not there, and we would deem this a non-work related outcome. if it does cross that 50% threshold, then yes, we would deem this, and the opinion would be COVID-19 transmission was likely associated with a workplace exposure and likely contributed as a main factor to the death, right? So it's a twofold, if you would, analysis of one, transmission, and two, death, that you will get with this depth of analysis in concert with your clinical consultant that would not be otherwise contemplated or addressed from doing just the exposure piece of it. And both are important, we believe, to make a full determination when we're talking about mortality in the workplace as a result of COVID-19 transmissions. So we're talking about this. Why? Obviously, because it's very impactful when you have a mortality. We know multiple employers are now seeing mortalities as a result of COVID-19 that weren't seeing it just 4 weeks to 6 weeks ago. Because the number of cases are growing. So this will be something you're likely to deal with if you haven't already, and having a game plan in place to deal with this causal association to the depth sufficient to mitigate risk from a litigation standpoint would be helpful as we see this pandemic continue to play out on months to come. So with that, again, we kept it a little light today, and I hope that you took away the nuggets here in terms of making sure you have a plan for causal associations, and hopefully have a clinical consultant standing next with you to help provide this depth of analysis. So with that, we'll stop, we'll take questions, and thank you.
Thanks, Dr. Harris. Just that you know, your voice has been fading out and in a little bit. So for the question period, you might want to just triple check your microphone there. Probably a little different in Anaheim than it is customarily in your home office. So we have a lot of questions, so I'm glad that we've got some time. I'll jump right in. The first is, I've heard from 2 family members who are ICU nurses dealing with COVID from the beginning, who will both be refusing the vaccination. What are your thoughts about that?
That's very interesting, right? Frontline workers refusing the vaccination. If they didn't give you a reason, please go back and ask them why. Perhaps it is because of some pre-existing condition they may have that would unlikely predispose them to a poor response from the vaccine. Unsure. But as far as we know now, if we're talking about the Pfizer vaccine, which is an mRNA vaccine, the mRNA vaccines have a phenomenally safe profile compared to other vaccines that we administer, and there is little risk, no risk virtually, that the vaccine itself can cause COVID-19 for sure. And the profile we're seeing for these mRNA vaccines in terms of adverse events is very minor. So I don't understand with the information provided in the question, what would limit their proactiveness for receiving the vaccine, as we know it is substantially efficacious for preventing COVID-19, or even at worst, if you're very cynical about the data, preventing poor outcomes from COVID-19, meaning that even if you take the stance of the vaccine only ameliorating the symptoms or risk of mortality, that's still a benefit in terms of outcome for the masses.
Okay. Several people are asking about the CDC's recent action reducing the quarantine time from 14 to 10 days. One of the questions is, what's your opinion about reducing the quarantine time? And do you think this will negatively impact employers and increase the spread of COVID-19 in the workplace?
Yes, so the quarantine time reduction is something that we anticipated from the CDC. Weeks ago, we started talking about reducing and recommending a reduction in quarantine, and have implemented that with some employers. And we know that because of data recently reviewed, most people are not infectious after that 10-day period after an exposure, right? The likelihood is low enough to warrant a reduction in quarantine. Furthermore, the quarantine can be shortened, right, to even further with a testing strategy that is implemented to determine someone's positivity for COVID-19 down to 7 days. And again, it's really a process by which we're trying to maximize the productivity of the workforce in general across the board in the US, get the economy in good shape, right? But mitigate risk for transmission. So in sum, we believe this will not be a deleterious effect in terms of protecting workers because we're looking at the data not prospectively, but retrospectively on who was infectious when and appropriately adjusting quarantine periods to reduce risk of workplace transmission.
Okay, there's a related question that just popped up, asking if WorkCare has already included this protocol in the Work Matters algorithm. And there's another related question that to elaborate on what you just said, and that the question is, do you recommend employers transition to the 7 or 10-day quarantine, 7 days with testing, 10 days without testing, as opposed to keeping with the 14-day quarantine to be on the safe side?
So it depends on a couple factors, right? In short, yes, we do recommend transitioning because we want to make sure we're not inappropriately increasing absenteeism, because we know that has an effect on not just productivity, but on employee morale, as well as overall weathering the COVID pandemic from a business standpoint, right? But at the same time, if you have a workplace in which it does not permit your workers to adhere to safe practices, social distancing, or even wearing masks, consider remaining at that 14-day quarantine because that is the more conservative approach. But if you are able to institute best practices with regard to protection of your workforce with PPE and administrative controls, then it is appropriate, and we do recommend a transition to the shorter quarantine period. We really are promoting the testing methodology because it adds an additional layer of assurance that the individual that is returning from their quarantine is negative. So again, it's playing the odds. It's not absolute, but it is substantiated with enough clinical data that we are going to do a good job with these reduced recommendations in place.
Okay, this question has come up before, and I think it kind of bears repeating because it keeps coming back up. There's a comment first. We're struggling with whether employees who have recovered from COVID should quarantine after close contact with an active case. If they are initially immune, should we assume that they are immune after 4 months? At some point in the future, we will also have the same issues with people who have been vaccinated. Do you have any comments or guidance?
I do, and since we have a little bit of time here, I'm going to see if I can pull up my PowerPoint I presented previously here. Bear with me 2 seconds. Well, while it's downloading, the short answer is yes, individuals should still quarantine after an exposure if they've previously had COVID-19, right? That's the short answer. For how long, obviously, becomes the next question. And if we look at the opportunity here that we presented recently, if everyone can see this on their screen, we're looking at an individual who, actually we're going to skip forward here a little bit. So if we're looking at the serologic strategy on those individuals who've been exposed, we have an individual who's asymptomatic, exposed to someone positive for COVID-19, but they have a positive history of COVID-19. These are the individuals that we recommend getting antibody testing for. And if that antibody test is positive, meaning they have active immunity against COVID-19 with a positive IgG and IgG, most likely their IgM would be undetectable if it's substantial time since their infection, then we can accelerate their return to work after that period of 24 to 48 hours, right? If it's negative, meaning that their immunity has waned, and they're likely now susceptible for a reinfection of COVID-19, then they continue their quarantine period appropriately. But this strategy involving testing serologically would permit us to return those workers appropriately who are demonstrating immunity. And again, the total savings in terms of time of absenteeism would be potentially 7, or in this case, 12 days, depending on the circumstance.
Okay, a couple people are asking about the recommended test. What's the optimal test, and when should it be performed after potential exposure? And then one other person wants to know, what's the point of even testing if someone is symptom-free and doesn't think they've ever been in contact with an infected person? Is there any point in testing?
Short answer there is no, no point in testing. If you've not been exposed and you have no other risk factors for having contracted COVID-19, then there's no need to test. We're talking and referring to antibody testing only for those individuals who have a positive exposure history, but also a history of having COVID-19 remotely in the past. So that's when this serologic testing methodology plays a significant opportunity, or introduces a significant opportunity for reduction in absenteeism as a result of a quarantine that's dramatically shortened. So when we're talking about testing that individual after an exposure, there is no necessary waiting period, right? We're not trying to detect a transmission event, meaning that we're not looking for any active viral particle or nucleic acid in the individual that's been exposed. We're only looking for existence of antibodies that were preformed during their remote infection. So even the same day of exposure, we can test the individual using this serology methodology, see who has immunity, and then anticipate their return to work. We recommend the 24 to 48 hour waiting period only because of access to testing, right? But if you have access to testing on site, then testing the day of exposure would be appropriate to understand who would likely have the much lower risk of transmission because of limited susceptibility as a result of their immune system's recognition of COVID as a result of that positive IgG.
Okay, well, we're getting a lot of questions, Dr. Harris, and we're
Love it.
out of time, but there's one more I want to ask because it's about the causal relationship, and you just covered that, but a lot of these questions we might want to revisit and address them next week. So those of you who didn't get your questions answered, we will answer in writing, but it's given me a couple of ideas of things that we can tackle in more depth next week. So we promise we'll get back to you. But the final question for today is, and a comment, I'm not sure how we prove a causal relationship to an exposure at work when we're dealing with an airborne virus. Having worked in a hospital for 20 plus years, influenza illness was never accepted as work-related, even if you had a known exposure at work, as you can't prove you got the virus from a patient or by providing patient care. Help me understand COVID and work-relatedness, as both COVID and influenza are spread the same way. The burden of proof is extremely difficult to establish from a legal standpoint. Also, we have to consider the difference of died with COVID as opposed to died from COVID.
Absolutely. So we did speak to the latter part of that question today in the presentation when we spoke about a twofold determination, right? The first determination being, did the worker contract COVID at work? Second determination is, did the worker succumb to or die as a result of their COVID infection primarily, or was it another cause of death? So absolutely agree that the latter point needs to be addressed in the analysis, in the causality analysis. That is why you need your clinical consultant to help you make that determination in concert with the other factors. Speaking to the difference between COVID and influenza, it is functionally different from a cluster standpoint and causality standpoint because of the impact of COVID. Again, if flu ever became the third leading cause of death in the US, I can almost guarantee that workplace exposure would be more stringently addressed by OSHA and others in terms of protecting workers. As we see it now, because of the substantial risk of exposure in the workplace, if precautions are not adhered to, that is why we have to dive deep into causality around COVID-19. Anecdotally, right, the companies that we were helping in Texas during the spring and summer, where in the meatpacking industry had a 63 to 65% positivity rate when testing their workers, was clearly associated with exposures in the workplace. And that was the need to do causal association and make a workplace determination is important for that reason, right? It's all about protection. And so if we neglect the opportunity to protect workers by understanding the causal relationship, then we're going to miss the opportunity again to really do a good job to help stem the tide of transmission. But the main difference from a susceptibility and transmissibility standpoint, airborne being airborne, there's not a lot of difference. What we're seeing, however, is just the level of susceptibility is far greater for COVID versus flu as it stands
today. You're fading
today.
out, Dr. Harris.
Oh, sorry about that.
Can you repeat that last little bit?
Yeah, so what we're seeing primarily in terms of the difference is susceptibility. COVID is, people are far more susceptible to airborne transmission of COVID than we've seen so far with the flu. Go back to that R0 number. Look at the R0 for flu compared to the R0 for COVID-19, and there is the basis for why protecting workers in the workplace from exposure is important.
Okay, well, again, I apologize we can't get to all the questions, but we will address them. Please check our website. And thanks to Dr. Harris, as always, for such an informative session. We really appreciate it. Everybody take care, and we'll see you next week.
Thanks, everyone. Take care, and God bless.